ക്ലാസ്സിൽ തീർച്ചയായിട്ടും വളരെ നല്ലതായിരിക്കും എന്ന് പ്രതീക്ഷിക്കുന്നു. ഈ ഫംഗ്ഷനിലേക്ക് സാറിനെയും പുരുഷോത്തം സാർ, സീനിയർ സാറുമായ പുരുഷോത്തം സാറ്, അനന്തേശൻ സാർ, ശ്രീനിവാസ് സാർ, IAP പ്രസിഡന്റ്, പിന്നെ ജോസിനെ കണ്ടിട്ടില്ല, എല്ലാവരെയും ഈ ഫംഗ്ഷനിലേക്ക് ഇൻവൈറ്റ് ചെയ്യുന്നു, സ്വാഗതം ചെയ്യുന്നു. താങ്ക്സ്. ജയ് IAP.
Next, invite Gobi Mohan sir, State Secretary IAP, to say a few words.
Babuji.
Gobi sir.
റിയാസ് ഉണ്ട്.
ആദ്യം പറയട്ടെ. റിയാസിനെ കണ്ടില്ല. ഗോപി സാർ ഇല്ലെന്ന് തോന്നുന്നു. റിയാസ് സാർ.
തോമസ്.
റിയാസ് സാർ. സാറേ.
റിയാസ് ആദ്യം ഒന്ന് പറഞ്ഞോട്ടെ, എന്നിട്ടങ്ങ് സ്റ്റാർട്ട് ചെയ്യാം തോമസ്.
റിയാസ് സാറേ.
Okay. I am actually just reaching home, so there is not much to say. I just offer my best wishes for the program, and today we have one of the most eminent teachers we can have to tell us about asthma, and we are very much obliged to sir for agreeing to this program on a very short notice. So we will listen to sir. There should not be any delay. Over to sir. Thank you.
സുകുമാരൻ സാർ സ്റ്റാർട്ട് ചെയ്യാം. Sir.
Thomas, can you see the slides?
Yes, sir.
Okay. Beloved State Presidents, Dr. Riaz, senior faculty members, Dr. Srinivasan from GINA Pondicherry, then Dr. Riaz, Dr. Anandakesavan, Dr. Purushothaman, and other senior faculty and beloved students. It gives me great pleasure and privilege to be here with you to talk on my favorite topic, pediatric asthma. And I should thank the organizers, especially Dr. Riaz, then Thomas, etc., for giving this opportunity. And I also very glad that Dr. Cyril has joined this program. Cyril has taken over as the HOD of Pediatrics ICH Kottayam. I should congratulate Dr. Cyril and wish Cyril all the best.
Congratulations, Dr. Cyril.
Thank you, sir. Years to come. So I'll be talking on pediatric asthma. It is difficult to cover pediatric asthma within 1 hour. So I'll be highlighting only a few points. Thomas, I think the slides are not moving now. Thomas.
സാറേ അതൊന്ന് ക്ലോസ് ചെയ്ത് ഒന്നുകൂടെ സാർ ഒന്ന് ഓൺ ആക്കാവോ അങ്ങനെയാണെങ്കിൽ പ്രസന്റേഷൻ? സാറേ ക്ലോസ് ചെയ്തിട്ടേ ഒന്നുകൂടെ ഒന്ന് ഓപ്പൺ ആക്കാവോ സാറേ കമ്പ്യൂട്ടറിൽ? സാർ ഷെയർ ചെയ്യുന്നില്ലേ ഇപ്പൊ?
ഷെയർ ചെയ്തായിരുന്നല്ലോ, ജസ്റ്റ് മൂവിങ്.
ഒരു മിനിറ്റ് സാറേ.
വയലിന്റെ ആവുകയാണെ ഡാമൊന്നും വിടണ്ട. വയലിന്റെ ആവുന്ന അടങ്ങി അവിടെ ഇരിക്കാൻ പറഞ്ഞു മനസ്സിലായി. അതിപ്പോ മറ്റേ അച്ഛൻ്റെ വയലന്റ് ആവാൻ വേണ്ടിയല്ലേ നമ്മൾ ഒതുക്കിയില്ലേ? ഏത് ആ ടാക്കി കാടിയേ
സാർ പോയോ? എക്സിറ്റ് ആയോ?
സാർ ഇല്ലല്ലോ.
സാർ എക്സിറ്റ് ആയി.
അങ്ങനെയായിരിക്കും. ഒന്നുകൂടെ കേറാനായിരിക്കും.
ഒന്നുകൂടെ കയറാനാണ്.
സാറിനെ ഒന്ന് വിളിച്ച് നോക്കണോ?
സാറൊന്ന് വിളിക്കാം അങ്ങനെയാണെങ്കിൽ.
ഞാൻ വിളിക്കാം. ഓക്കെ.
ഗോപി, നമ്മളെ ഈ മ്യൂട്ട് ചെയ്യാനൊക്കെ ആരെയും കോഹോസ്റ്റ് ആക്കി
ഞാൻ
വെച്ചിരുന്നു.
ഒരാളെ ഇപ്പൊ ഒരാളെ ആക്കിയിട്ടുണ്ട് സാറേ.
ഒന്ന് പറയാൻ അത് കറക്റ്റായിട്ട് ചെയ്യണം. ഭയങ്കര നോയിസെൻസ് ആവണം. അല്ലെങ്കിൽ ഞാനുള്ള സാറെങ്കിൽ എന്നെ കോഹോസ്റ്റ് ആക്കിയാൽ മതി, ഞാൻ ചെയ്തോളാം.
ഞാൻ സാറിനെ കൂടെ കോഹോസ്റ്റ് ആക്കാവേ. ആതിരെ ആക്കിയിട്ടുണ്ട്.
ആതിരെ ചെയ്തോളൂ സാറേ.
ആതിരെ ആക്കിയിട്ടുണ്ട്, കോഹോസ്റ്റ് ആക്കിയിട്ടുണ്ട്.
പെട്ടെന്ന് വരുമ്പോ ഇച്ചിരി ഡിലേ വരുന്നേ ഉള്ളൂ സാർ. അല്ലെങ്കിൽ പുള്ളിക്കാരത്തി ചെയ്തോളൂ. 9 വരെ പുള്ളിക്കാരത്തി ഉണ്ട് സാർ.
ഗ്യാസ് സാറിനെ വിളിക്കുന്നുണ്ടല്ലോ അല്ലേ?
പുരുഷോത്തമൻ സാറിനെ ഞാൻ ഹോസ്റ്റ് ആക്കിയപ്പോ ഞാൻ കോഹോസ്റ്റ് ഒന്നും അല്ലാതായി. കുഴപ്പമില്ല, സാർ എന്തെങ്കിലും ചെയ്താൽ മതി.
ഞാൻ ചെയ്യാം. കോഹോസ്റ്റാ ഞാൻ ഉദ്ദേശിച്ചിരുന്നത്. എനിക്കിത് മ്യൂട്ട് ചെയ്യാനുള്ള സംഭവം.
ഞാൻ അറിയാതെ ഹോസ്റ്റ് ആക്കി പോയി സാറിന്. അപ്പൊ ഞാൻ ഒന്നും അത് സാരമില്ല.
അല്ലല്ല, ഒരു കാര്യം ചെയ്തോ. അത് തിരിച്ചെന്നെ ആക്കിക്കോ, കോഹോസ്റ്റ് ആക്കിയാൽ മതി.
അല്ല, സാർ എന്നെ കോഹോസ്റ്റ് ആക്കിയാൽ മതി. സാർ എന്നെ എനിക്കിതൊന്നും ചെയ്യാൻ പറ്റില്ല അതില്. സാറാ ഹോസ്റ്റ് ഇപ്പൊ.
ഓ അയ്യോ, അതെന്താ ഇപ്പൊ ചെയ്യേണ്ടതെന്നൊന്നും പറഞ്ഞു.
കുഴപ്പമില്ല സാർ, ഒന്നും ചെയ്യണ്ട. കുഴപ്പമില്ല, അങ്ങനെ പൊക്കോളൂ.
ഓ ഓ ഓ, അത് ശരി.
പൊക്കോളൂ സാർ.
പാർട്ടിസിപ്പൻസിൽ പോയിട്ട് ഞാൻ തന്നെ ഹോസ്റ്റ് ആക്കേണ്ടി വരും അല്ലേ?
അതെ, കാരണം ഞാനതപ്പോ ഔട്ടായി. ഞാൻ സാറിനെ ഹോസ്റ്റ് ആക്കിയപ്പോ ഞാൻ
ആസ്ക് ടു സ്റ്റാർട്ട് അതില് മേക്ക് ഹോസ്റ്റ് അല്ലേ? എത്രയല്ലേ?
കോഹോസ്റ്റ് ആക്കിയാൽ മതി സാറേ.
അല്ല, മേക്ക് ഹോസ്റ്റ് ആക്കി.
ശരി ശരി. സാർ സുകുമാരൻ സാറിനെ കൂടെ നാക്കാവോ?
ഓക്കെ ഓക്കെ.
അപ്പൊ സാറിന് പ്രസന്റ് ചെയ്യാൻ പറ്റുള്ളൂ.
അല്ല, എനിക്ക് ചെയ്യാൻ പറ്റുമല്ലോ അല്ലേ?
പറ്റും, സാറിന് പറ്റും.
അതിൻ്റെ അകത്ത് ഇല്ലല്ലോ ഗോപി. ഗോപി ചെയ്താൽ മതി.
ലതിക മാഡത്തിന് ഒന്ന് ആക്കാൻ പറ്റുമോ? മാഡം കോഹോസ്റ്റാ.
ഞാനോ?
മാഡം കോഹോസ്റ്റ് ആണ്. മാഡത്തിന് ഓൾറെഡി കോഹോസ്റ്റ് എന്നാ കാണിക്കുന്നതിന്റെ.
അപ്പൊ ആരെയാക്കണ്ടേ?
മാഡം സുകുമാരൻ സാറിനെ ഒന്ന് കോഹോസ്റ്റ് ആക്കിയാൽ മതി മാഡം.
ഓക്കെ, നോക്കട്ടെ കേട്ടോ.
സുമാർ സാർ വന്നോ? എത്തിയോ?
അത് എങ്ങനെയായിരുന്നു ചെയ്തത്?
അതിലൊന്ന് ക്ലിക്ക് ചെയ്തേ മാഡം. അതിലൊന്ന് ക്ലിക്ക് ചെയ്തേ. ആ ഫോട്ടോയുടെ മേലെ, സാറിന്റെ ഫോട്ടോയുടെ മേലെ ഒന്ന് ക്ലിക്ക് ചെയ്തേ. അപ്പം അതിലേക്ക്
പറ്റുന്നില്ല.
വരും, കുറെ ഓപ്ഷൻസ് വരും. അല്ല സാറേ, കോഹോസ്റ്റ് അല്ല ഇപ്പൊ. അതാ
അതിന്റെ അകത്ത്. പക്ഷേ
റീനെയിം അങ്ങനെയൊക്കെയാണല്ലോ പറഞ്ഞേ.
അല്ല, അതിന്റെ താഴോട്ട് സ്ക്രോൾ ചെയ്തേ മാഡം. അതിന്റെ താഴോട്ട് സ്ക്രോൾ ചെയ്തേ. പറ്റുന്നില്ല.
ഇല്ല, അതിലങ്ങനെ ഓപ്ഷൻ ഇല്ലല്ലോ.
വർഗീസിന് ചെയ്യാൻ പറ്റും. വർഗീസ് ഹോസ്റ്റാ.
ഞാൻ നോക്കട്ടെ. ഞാനിപ്പോ ഹോസ്റ്റായി. ഞാൻ ആക്കിക്കോളാം.
ഗോപിക്ക് ചെയ്യാൻ പറ്റും.
ഇപ്പൊ ആക്കി സാറേ.
Oh. Mm. Yeah.
ഫുൾ സ്ക്രീൻ ആക്കിയാൽ മതി
Full
സർ.
screen ആക്കണം.
Okay.
ആ.
ശരി
ഒരു
correct
minute,
sir.
ഒരു minute. Okay.
Okay sir.
I think we'll proceed now. Okay, I think there is some problem, and even
Okay.
when before you start the talk, I have just tried the share, but you were sharing very well at that time, and now there was some problem. So, beloved friends, I'll be talking on childhood asthma now. It's a very big topic, so I'll be covering mainly prevalence of asthma, diagnosis of asthma. Then I will be talking on recent GINA guidelines 2024, prevention of asthma, and I will try to summarize. These are some of my biodata. I leave that. These are some of the books written by me, and I have written the book on management of childhood asthma. It is published by AP Publications and just published years back. And this is my recent book on recent advances in pediatric asthma. This is published by Nobel Publishers, Delhi. And first, I will be talking something about prevalence of asthma and my own studies on asthma. See, the largest study group which has conducted a study on prevalence of asthma is by the ISAC study group. ISAC stands for International Study on Allergy and Other Allergic Disorders, Asthma and Other Allergic Disorders in children. And this study group has conducted a prevalence study on asthma in 56 countries, and study population was 4.5 lakhs of children. And I happen to be the chief investigator from Kottayam district, Kerala. And we have seen that the prevalence in Kottayam district is very, very high. And you can see a red star which shows the prevalence of more than 9%. Our prevalence was nearly 25%. I don't know why it is like that, but you can see the red stars are mainly seen in English-speaking countries like America, New Zealand, Australia, and Kerala in India. Is it due to urbanization? Is it due to air pollution, or can it be explained by the hygiene hypothesis? As you all know, as hygiene improves, the incidence of allergic disorders also increases. We don't know exactly like that. These are a few of my studies, and my last study was conducted in 2014. I have conducted this study as a part of my PhD. My PhD thesis was on environmental trigger factors and prevalence of asthma. It was conducted in Mahatma Gandhi University, and the study was conducted in Kottayam, Alleppey, and Idukki district. As you know, Alleppey is a coastal area, Kottayam is the center, mid part of Kerala, and Idukki is the high ranges. We just want to know the prevalence of all these allergic disorders, and we have studied almost 12,000 children for the prevalence of asthma, but all these are questionnaire study. So there are some limitations for this questionnaire study, and also the diagnostic area may be different in different studies. Again, along with asthma also, allergic rhinitis also we have seen high prevalence. In the ISAC study also, the maximum incidence of allergic rhinitis, more than 40% was reported from Kerala. Then atopic dermatitis around 5 to 8%. Then again, this ISAC study was conducted from 1995 to 2015. After 2015, this ISAC study was replaced by a study called GAN study. GAN study is a multi-centric study conducted in different countries. And from India, there were 9 centers from Kottayam, Mysore, Pune, then Jaipur, New Delhi, Lucknow, Calcutta, Chandigarh, and Bikaner. Dr. Minu Singh from Chandigarh was there, and also Dr. Kabra from All India Institute was there for this study. And Dr. Virendra Singh from Jaipur was the principal investigator of this GINA study. GINA study has again published, and this picture the prevalence of asthma ever in adolescents, and rest star shows the increasing prevalence. And again, the summary of the study is that there were 19,795 participants from 27 centers in 14 countries. And there were 74,361 children in 13 to 14 years, and 45,434 people in 6 to 7 years old. And in this GAN study, in one center, we have studied 12,000 people, 300 children in 6 to 7 years, 300 in 13 to 14 years, and their parents, their father and mother. So it comes to 12,000 children. And it has seen that over 27-year period, children and adolescents showed a significant decrease in percentage point of prevalence per decade in severe asthma symptoms. But an increase in asthma was seen at all ages. Mainly they manifest as night cough. Again, this is a summary. The summary of this GAN study shows that the prevalence of current Bs has decreased in low-income countries in 13 to 14 years. I don't know whether it's decreased in low-income countries, but the prevalence has increased in lower and middle-income countries in 13 to 14 years old, and it was stable in upper, middle, and high-income countries. And this GAN study again shows that the prevalence of asthma, prevalence of allergic rhinitis is very high, about 40% in India. Now, coming to the diagnosis of asthma, previously we thought that asthma is a clinical diagnosis. Any PGs who know the criteria for diagnosis of asthma? PGs can answer. Nittu Joseph is there. Nittu Joseph. Aishwarya is there. Any PG? No, they are not taking up. We thought it was a clinical diagnosis. So if a child is presented with more than 3 episodes of wheezing per year, and if the wheezing is reversed with a bronchodilator or spontaneously, and after ruling out other causes of wheezing in a child, he can make a clinical diagnosis of asthma in a child. And so you must rule out other causes of wheezing in a child. Do you know what are the causes of wheezing in a child? Nitu is there. Nitu Joseph. Aishwarya. They are not there. I will tell. See, when you look for clinical features of wheezing, cause of wheezing, I usually say one should remember A, B, C of wheezing. Condition starting with A, mainly is asthma phenotypes, aspiration syndrome. B may be bronchiolitis, bronchiectasis, bronchopneumonia, etc. C, cardiac failure, congenital malformation, like cystic adenoma malformation, and then sequestration of lung and cardiac failure. D, drugs can produce wheezing, especially beta blockers and non-steroidal anti-inflammatory drugs can produce wheezing. Then E is extrinsic compression of the bronchus by a lymph node, a tuberculous lymph node or lymphoma pressing on the bronchus, they can present with wheezing. And then F is very common in children. F stands for foreign body. G stands for gastroesophageal reflux. H is H-type tracheoesophageal fistula. Then I may be interstitial lung disease, immunodeficiency. And lastly, there's a condition called vocal cord dysfunction syndrome. All these conditions can present with wheezing, especially in under 5 years. Under 5 years, there are a lot of mimics for wheezing. And what are the main clinical symptoms of asthma? Asthma usually manifests as recurrent episodes of cough, wheezing, chest tightness. Then in cough in asthma, the cough is mainly nocturnal. A child who wakes up around 2 a.m., 3 a.m. With cough, and if you see a bronchodilator, and if the cough subsides, most probably it is asthma in a child. But in addition to the classical presentation, asthma is said to be an iceberg disease. And some of the children, they can present with the recurrent episodes of pneumonia. If a child is presented with recurrent episodes of pneumonia at multiple sites, maybe due to asthma, or they can present with a chronic cough. The commonest cause for a chronic cough in a child will be asthma. So there is a varied clinical presentation for asthma in a child. And even though I said clinical, the recent GINA guidelines 2024, they say that all children with asthma, you must do a spirometry if possible. In those children above 6 years, you must do a spirometry and look for any evidence of airway obstruction, mainly you must look at FEV1, FEVC, if it is less than 90%. And if the FEV1 increases by more than 12% after giving a bronchodilator, especially salbutamol 200 to 400 micrograms, and if the FEV1 increases by 12%, it may be asthma. But if facilities are not there, you can use a PEFR. Again, it is used for children above 6 years. The PEFR increases by more than 20% after giving a salbutamol nebulization 200 to 400 micrograms. It may be asthma. But now, in children less than 6 years, small children, one can do what is called a forced oscillometry test can be done. This infantile oscillometry may give a clue for diagnosis of asthma in small children less than 6 years. Then coming to other investigations like a total count, differential count may not help you, and most of the allergic disorders, eosinophilia may be there. Then coming to total IgE may not help you very much. IgE may be elevated in all allergic disorders and also in children with helminthiasis, collagen muscular disease. It may be elevated, so it will not help you. But in a child who is presented with a persistent wheeze, and if the IgE is very high, more than thousands, you may suspect an allergic bronchopulmonary aspergillosis. In allergic bronchopulmonary aspergillosis may be complicated by asthma, the IgE may be very high. Then coming to skin prick test and allergen-specific IgE. These tests are not routinely done in children with asthma, but in a child in whom we are planning for immunotherapy. A child who is not responding to the pharmacotherapy, and the child is having a persistent allergic rhinitis or food allergy, you may do a skin prick before you go for an immunotherapy. And also, it's very important that you must look for allergen-specific IgE before immunotherapy. These are a few indications for doing a skin prick test and allergen-specific IgE. So to conclude, asthma is mainly a clinical diagnosis, but if facilities are available before starting treatment, it is important that you can do a spirometry or post-oscillometry can be done in children. Then coming to some of the recent trends in the management of asthma. This is again the fundamental change in asthma management occurred with GINA guidelines 2019. In 2019, they said that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. They said in 2019. But 2024, they say even for children above 6 years, you should not do salbutamol alone. And salbutamol should be combined with inhaled corticosteroids. For safety, GINA no longer recommends SAFA alone for treatment in adolescents and children above 6 years. This decision was based on evidence that SABA only treatment increases risk of exacerbation and risk of death is very high if you use SABA alone. So GINA now recommends that all adults and adolescents with asthma should have ICS containing controller treatment to reduce the risk of serious exacerbation. ICS can be delivered by daily treatment in mild asthma or as a needed low-dose ICS formoterol. This is a population level risk reduction strategy, less like we give statins for treatment of hypertension. Now, coming to step-up management and for the long term, when you see a child with a long-term management, in long-term management, one should remember 3 P's in a long-term management of asthma. Most important is pharmacotherapy. Second P is prevention of trigger factors. You must look for all the trigger factors. And thirdly, patient education. As Dr. Cyril has said, along with patient education, you can have parent education, practitioners education, physician education, pediatrician education. Is very, very important in the long-term management of asthma. Now, coming to the long-term management of asthma, when you consider the treatment of asthma, you can divide these children into 3 groups. Children less than 5 years, 6 to 11 years, about 12 years, adolescent and adults. Then coming to the long-term management of children with asthma, as you all know, Asthma is a chronic inflammatory disease with airway obstruction. So for a chronic inflammatory disease, the best drug is inhaled corticosteroids. But should you give inhaled corticosteroids for all children? In children less than 5 years, the GINA recommends that in step 1, no long-term anti-inflammatory drugs are required. In step 2, we can give low-dose inhaled corticosteroids. For corticosteroid, there are 3 dosage schedule are there. One is low dose, medium dose, and high dose. If we take the case of budesonide, the low dose is 100 to 200 micrograms, medium dose is 200 to 400, and high dose is above 400 micrograms. So in step 2, you can have a low dose inhaled corticosteroid from 100 to 200 micrograms. Then if they are not responding, you can have a step up. They say that in step 3, you can double the dose of inhaled corticosteroid. Then if the child is not responding, then the child should be referred for a phenotyping, and the child should be referred for a pulmonologist or a specialist to find out what is the cause for wheezing. The wheezing may not be due to asthma. So this is a long-term management in children less than 5 years. The most important thing here is that the drug that I have not mentioned is long-acting beta-2 We have got mainly 2 long-acting beta-2 salmeterol and formoterol. Of this, salmeterol is a better drug because it acts quickly. So it acts as a controller, it acts as a reliever as well as controller. But formoterol should not be used in children less than 5 years. It should be given in children above 6 years only. Because the studies on the side effects of formoterol is not well studied in children less than 5 years. And also it is seen that there are cardiac problems are reported with formoterol in small children. So it is better to avoid formoterol in children less than 5 years. So less than 5 years, the drug of choice is low dose inhaled corticosteroid, not responding, double the dose of inhaled corticosteroid. As I said, I already discussed the management in children less than 5 years. Then children in the 6 to 11 years and children above 12 years. Now coming to the management in children 6 to 11 years. 6 to 11 years, in all these children, you must assess and confirm the diagnosis and look for associated comorbidities. In all children, you must look for associated comorbidities. The common comorbidities are allergic rhinitis, then gastroesophageal reflux disease, adenoid hypertrophy, and obesity, and also depression may be associated comorbid conditions. Then depending on the symptom, you start treatment. In step 1, you start with a low dose inhaled corticosteroid taken whenever SABA is taken. So the long-term short-acting, long-term budesonide is not used, but when the child is given a short-acting beta-2 agonist, you combine it with inhaled corticosteroid. Then step 2, daily low dose of inhaled corticosteroid. And step 3, you can have 3 options. Low dose inhaled corticosteroids with LABA, or medium dose inhaled corticosteroid, or very low dose of ICS with formoterol. Step 4, medium dose inhaled corticosteroid with LABA, or low dose inhaled corticosteroid with formoterol, maintenance and reliever therapy. It's called MART therapy. MART stands for maintenance and reliever therapy. So if you use formoterol, it acts as a controller as well as a reliever. Then if the child is not responding, we must give higher dose of inhaled corticosteroid with LABA, or there is some role for oral corticosteroid, or we must try biologicals like anti-IgE, omalizumab. There are a few other options are there. You can see the lower down discount that daily leukotriene receptor antagonist can be combined with inhaled corticosteroid. When you consider LABA, when you compare leukotriene receptor antagonist, especially montelukast, montelukast is prescribed left and right, but the anti-inflammatory property of leukotriene montelukast is very inferior to inhaled corticosteroid. The drug of choice should be inhaled corticosteroid. But those parents who don't like to have inhaled corticosteroid or steroid phobia is there, then you can try leukotriene receptor antagonist. And it is now recommended by FDA that it can produce a lot of neuropsychiatric manifestation. especially in adolescents, can produce hyperactivity, reduced attention span, poor scholastic performance, etc. In step 4, another option is you can add tiotropium bromide, which is an activities on acetylcholine agonist. Tiotropium bromide, antimuscarinic agent, tiotropium bromide can be used. And another option in step 5, you can have oral corticosteroids, or you can try other biologicals like mepolizumab, bendalizumab, or dupilumab. So this is a summary of this. Take ICS whenever SABA is taken. Step 2, low dose inhaled corticosteroid. Step 3, low dose inhaled corticosteroid, LABA, or medium dose ICS, or very low dose of MAT therapy, then a high dose of MAT therapy. And if the child is not responding, they should be referred to an expert. Now, coming to the management in children, 12 years and adults. In 12 years and adults, for clarity, the GINA treatment figures there are 2 tracks based on the relief is used. This is either a track 1 or track 2. In track 1, the main difference is that in track 1, you use a combination of budesonide with formoterol as a reliever, whereas in track 2, the alternative is salbutamol, is short-acting beta-2 agonist with budesonide. And here you can see that there are a few other options are there. In step 2, in addition to low dose of minimus ICS, you can try SLIT therapy. SLIT is sublingual immunotherapy is being tried. And GINA guidelines also recommend sublingual immunotherapy in step 3 and step 4. And step 5, you can try antimuscarinic agents like tiotropium bromide and other biologicals like anti-IgE or anti-IL-5, which is mepolizumab, or anti-IL-4, which is bendalizumab or dupilumab is considered. And last step, you consider high dose of inhaled corticosteroid with LABA. So in the previous guidelines, there is no mention about sublingual immunotherapy in asthma. Now the main indications for immunotherapy is step 2, step 3, step 4. If a child is not responding to pharmacotherapy and the child is having associated allergic disorders like allergic rhinitis and for food allergy, we can try immunotherapy after doing a skin prick test or specific IgE. And if the child is allergic to one or two allergens only, then you can try immunotherapy. So this is a summary of what I have told. In the track 1, you can use as needed low dose inhaled corticosteroid with formoterol. Step 2, as needed low dose inhaled corticosteroid with formoterol, low dose ICS with formoterol, and medium dose of inhaled corticosteroid with formoterol. In step 2, the control of choice should be ICS with SABA. Track 1, it is always budesonide with formoterol, whereas in track 2, you can use salbutamol with ICS. Then once the child is given a prophylactic treatment, if the child's symptoms are controlled for a minimum of 3 months, then you can start step down, stop the first drug that is start first, that will be stopped, followed by the second drug gradually. And now I will talk something about the newer biologicals used for treatment of asthma. The common biologicals include omalizumab, is available as Solier. It's a monoclonal antibody which blocks binding of IgE to high affinity IgE receptors on the mast cells and prevent their activations by allergens. It blocks binding of IgE to low affinity IgE receptors on other inflammatory cells, including T and B cell lymphocytes, macrophages, and possibly eosinophils to inhibit chronic inflammation. And they reduce the level of circulating IgE. And you can see that IgE is mainly given for children above 6 years only. In those children with allergic asthma, not responding to ICS and LABA above 6 years, there's some indications for giving omalizumab. And another indication for omalizumab is spontaneous urticaria, chronic spontaneous urticaria. This is given subcutaneously. The dosage of omalizumab is depending on the IgE level. The usual dose is 150 to 300 micrograms. And one of the side effects is anaphylaxis, and it can produce atherothrombotic episodes. This is not studied in children less in the age group of 0 to 4 years. That's got a minimal oral steroid sparing effect is there, but the cost is very high. Another drug is mepolizumab. We are talking about mepolizumab in the guidelines. It is there. It's a humanized monoclonal antibody against interleukin-5. Interleukin-5 is felt to be the most specific cytokine in the eosinophil regulatory pathway. Another new drug is rituximab. It is another anti-IL-5 monoclonal antibody. Similar indications for eosinophilic asthma. This is used in children with higher eosinophilic count, but on greater predictive value for sputum eosinophilia. One major difference from mepolizumab is this requires IV infusion instead of subcutaneous injection. And rituximab is indicated in children above 18 years. Another noteworthy mab is benralizumab, which also targets IL-5. Dupilumab is directed against IL-4 receptors, and this is mainly indicated in children with atopic dermatitis. This is designated as a breakthrough drug by FDA, effective for eczema, atopic dermatitis as well. And it is just started, people have started using dupilumab in atopic dermatitis. Oligonucleotides, they augment CDF4 differentiation by shifting the balance from TH1 to TH2 and decrease the production of IgE. Then there are a lot of literature, a lot of controversy regarding vitamin D supplementation in asthma. Antenatal vitamin D supplementation, can it prevent asthma later? And there are some studies which shows some favorable effects, and they say that vitamin D supplementation in antenatal period will modify asthma risk in infancy. But further studies are required to prove this. So there is no room for routine vitamin D supplementation for antenatal mothers to prevent vitamin D. Vitamin D and childhood asthma, the Cochrane review offers some protection against severe attacks in adults with mild to moderate asthma. It is in adults. Further trials are needed in children who experience frequent severe asthmatic attacks. We have seen that some of the reports says that in those children with acute severe asthma, vitamin D level may be low and supplementation may be beneficial. And again, the routine supplementation is not. Now, coming to prevention of asthma, what are the steps that can be done for prevention of asthma in children? Exclusive breastfeeding. One of the strategies that can prevent the recurrence of asthma is exclusive breastfeeding for up to 6 months. Then you compare vaginal delivery with cesarean section. It is seen that the prevalence of asthma is higher in children born by cesarean section. So you must prefer vaginal delivery. Judicious use of antibiotic in first 1 year of life. That is very, very important. Unnecessary use of antibiotic in first 1 year, especially first month of life, is very, very important because it will alter the all the bacteria in the GI tract of children, and it can lead to increased incidence of asthma later. And avoid paracetamol in infancy. That is also very important. Injudicious use of paracetamol in infancy, especially first 1 to 3 years, 1 to 3 months, may be associated with high incidence of asthma. Discourage early introduction of risk food like milk, egg, peanut, seafood, and meat. Avoid exposure to animal dander. Avoid exposure to dust mite, the commonest organism that produces trigger with asthma. The commonest pollutant is dust mite, and dust mite can be prevented by immunotherapy and other supportive measures. Then coming to sublingual dust mite immunotherapy and asthma, sublingual immunotherapy against human dust mite can reduce the severity of asthma. Chronic allergen exposure plays a direct role in the exacerbation risk, and if reduced, modifies asthma later. Then coming to a natural history of asthma. When I was talking about the under 5 essays, according to the according to the European Respiratory Society, there are two groups are there. One is called an episodic viral wheezer and second is called a multi-trigger wheeze. In children with episodic viral wheeze, children less than 5 years were presented with the recurrent episodes of wheeze. With a viral prodrome, they will present with fever, infection with rhinovirus infection, rotavirus infection, human metapneumovirus infection can trigger asthma. And if you follow up these children, there will be no family history of atopy or personal history of atopy. They become symptom-free for five years of life. More than 90% of children with virus-induced wheeze, they become symptom-free. But other disease is called a multi-trigger wheeze. Multi-trigger wheeze, other than viral infection, exposure to other aeroallergens, especially passive smoking, can lead to asthma. And usually these children will have a positive family history of asthma or a personal history of atopy, like atopic dermatitis may be there. And it is found that those children with a multi-trigger wheeze, with multiple trigger factors, they may continue as asthmatic later on. Whereas 90% of children with a virus-induced wheeze, they become symptom-free by 5 years of life. 30% outgrow at 5 years, 60% at 8 years, and 90% of children become symptom-free by 14 years. 45% may relapse at 20 years to outgrow at the age of 14 years of age. And it's seen that 33% relapse at 28 years of age when outgrown at 21 years of age. So they can be relapsed later. So the main carry-home message is prevalence of asthma is decreasing in low-income countries. We don't know why it is so. Diagnosis of asthma is mainly clinical, but it is very important that if spirometry is there, we can do a spirometry. Spirometry should be done in all children above 6 years. Aerosol therapy has revolutionized the management of asthma. It is very important that almost all drugs available for treatment of acute asthma and persistent asthma, they are available as inhalers. And also it is very important to select the correct inhaler device for the age. In children less than 4 years, you can use a mid-dose inhaler with spacer and a mask. Children above 4 years, the preferred choice will be an mid-dose inhaler with a spacer. And above 5 years, you can use also a tripod inhaler can also be used. And nebulizer, home nebulizer should not be used because you must discourage the use of home nebulizers because the drug deposition by a nebulizer is only 1 to 5%, and people will develop overconfidence on nebulizers and it can produce ventilation perfusion mismatch. So it is better to avoid home nebulization in children. Phenotyping and genotyping are excellent for optimization of treatment. Those children with persistent asthma should have a long-term control of mainly inhaled corticosteroid. Now the control of choice should be a MART therapy, maintenance and reliever therapy, the combination of budesonide with formoterol. Patient education, as I said before, patient education, prevention of trigger factors are very important in the long-term management of asthma. Asthma is, regarding to asthma in adolescents, I just want to discuss few points regarding asthma in adolescents. Asthma is more in urban than rural adolescents. Urban adolescents start smoking earlier than rural adolescents, but after 18 years, the rural adults overtake urban adults in tobacco smoking. This the commonest trigger factor, the pollutants or irritants is tobacco smoking. In my study also in Idiki district, I was shown that more than 75% of the people, the trigger factor is passive smoking, and the main culprit is the grandparents. The grandparents keep their children in their lap, and they will go on smoking. And if the mother of the child asks the grandparents to stop smoking, they will not stop smoking, and it will result in a family calamity. So in all respiratory problems, not only for asthma, in children presented with the recurrent episodes of wheezing, recurrent pneumonia, recurrent ASOM, recurrent acute upper respiratory infection, we must ask the history of tobacco smoke, and tobacco smoke should be banned legally. Urban adolescents coming from schools in higher traffic area suffer more asthma than lower traffic area. So the traffic is high, the chance of asthma is high because of the vehicular pollutants. Pets are not a major source for increased prevalence of asthma in our country. It is said that regarding pets, there are a lot of controversies. It is said that there are some studies which shows that early exposure to pets in early infancy can protect these children from development of asthma. But definitely, exposure of pets in late infancy or older children, definitely it can trigger asthma. Then urban slum adolescents suffer more than urban elite and rural adolescents. Indoor air pollution and exposure from cooking fuel in ill-ventilated huts has changed the gender ratio of asthma, where girls suffer more than boys, since girls spend more time in kitchen. So in adolescent girls, now we see more incidence of asthma. The main culprit may be the cooking gas. Then I have just talked about long-term management of asthma. You must know something about acute management of asthma. I will just highlight a few points regarding acute management. When you see a child with asthma, you must try to acute asthma. You must try to grade these children. And there's an index called Asthma Predictive Index, API. Asthma Predictive Index is not Asthma Predictive Index. It is what is that called? You can PSI. It is called PSI is there. You can assess the severity of asthma by using PSI. In PSI, we look at the respiratory rate, wheezing, and use of accessory muscles of respiration. And the PSI is more than 6. These children should be admitted in the ICU. And in the ICU setup, you monitor saturation. Most important thing is you give oxygen to maintain saturation above 95%. The first drug of choice should be definitely salbutamol for treatment of acute asthma. Salbutamol 0.3 milligram per kilogram body weight. You can give 3 doses at 20 minutes interval. If not responding, you add ipratropium bromide. If not responding, the next drug should be IV magnesium sulfate, 30 to 50 milligram per kilogram body weight to be given in 30 minutes time. Other options, if not responding, the other options may be IV terbutaline. Unfortunately, terbutaline is not easily available now, terbutaline infusion. If not responding, you may go for the very old drug, aminophylline. The role of aminophylline in treatment of acute asthma and persistent asthma is limited. In according to the new GINA guidelines 2024, they say that the oral theophylline should not be used in children above, should be used in children about 12 years only. In less than 12 years, you should not use theophylline, oral theophylline, because the side effects are more, drug interactions are more, so it should not be used. And the better bronchodilator will be salbutamol rather than theophylline. And for treatment of persistent acute asthma also, acute severe asthma also, the indication for giving aminophylline is in a PICU setup, and the child is not responding to salbutamol, ipratropium bromide, IV aminophylline, IV terbutaline. You may give IV aminophylline. So its indication is limited, and those children who are not responding this kind of treatment, you can go for ventilation if required. But I have seen the most of these children, I have not ventilated any child with asthma. Most of the children, they will respond to this line of management. Once the acute symptoms are over, these children should be given a prophylactic treatment depending on the severity of asthma. To conclude this talk, I once again thank the organizers for giving this opportunity. And this is one of the very favorite subject to me. And the prevalence of asthma, even though decreasing in low-income countries, is again increasing. It is very important that asthma is again a clinical diagnosis. Facilities are there. You must go for a spirometry. And all children should have a preventer depending on the severity of the illness. And the best preventer now is a combination of budesonide with formoterol. You can have what is called a MART therapy. It may be a very low MART therapy, or high MART therapy. Thank you very much for your patient listening. Any questions we will pick up. Thomas, any questions or comments? Vishwadhan, sir?
Sir, I was waiting for Srinivasan sir to.
No, Srinivasan, sir.
No. It's really a wonderful learning experience and all the recent advances. So I didn't want to miss. Thank you. It's always a pleasure listening to all of you.
Sir, you close that window, sir. That sharing, sir. Sir,
There was a question in the chat box.
Yeah.
Sir, I will read. Does nifedipine have any role in the prevention of exercise-induced asthma?
Exercise-induced asthma, I think in exercise-induced asthma, the drug of choice there are two types of exercise-induced asthma. In a child with a persistent asthma, if it is not well controlled with the inhaled corticosteroid, they can present with exercise symptoms. And other is the true exercise-induced asthma, child developing wheezing on exercise. For exercise-induced asthma, first of all, the persistent asthma should be controlled. It should be controlled very well. Then the second thing is the drug of choice is one is you must give a short-acting beta agonist, salbutamol, 200 to 300 micrograms, half an hour before exercise. That is the first choice. And second choice may be montelukast, and you must give adequate inhaled corticosteroid for prevention of wheezing. So the drugs
Can I ask one question?
Yeah.
So what is your opinion about montelukast and suicide? Because it was, a few cases of suicide has been.
Yeah, sir.
So how often you have been using?
I haven't seen about suicide, but sir, I
Yeah.
have seen hyperactivity. Hyperactivity is very, very commonly seen. Recently, I saw a child who has come from Gulf. They came to Kerala for a marriage. This boy was hyperactive. They are not. They have come for the marriage ceremony, but he was not staying in the house. He is running around. So the parents took him to me. Then when I took the history, this child was started on montelukast some 1 week back. After stopping montelukast, everything subsided. So hyperactivity I was seeing.
But have you been using it rarely, occasionally?
Rarely, I rarely use, and I don't use a combination of montelukast with levocetirizine, antihistamine. That combination should be discouraged. Now, a lot of combinations are coming up. Montelukast with even belastin, all these antihistamines are coming up, and there is no road for that. If you want to give, you give separately.
Gobi, may I ask a question to sir?
Yeah.
Sir, regarding the use of the biologicals in asthma, throughout Kerala, which all centers at present are using these biologicals, and we need to report this thing, or there should be it should be presented in the respiratory chapter of IAP regarding the use of these biologicals. So we routinely talk about the guidelines and the fifth stage it should be used in different ages, but we are not sharing the experience of the people.
See, Purushothaman, I have not used. I have used this one. This one. What is that? IgE. Omalizumab only for one child, and it was started by Dr. Rajesh from Amrita. Amrita people they are using. Rajagiri they are using. This is mainly adult pulmonologists. In pediatric age group, there is no much indications. Most of the children with asthma, they usually respond to a combination of inhaled corticosteroid with formoterol. That will be ideal combination. Most of the children, and usually we see children with mild persistent asthma moderate, severe persistent unresponsive cases we are not seeing. And also regarding immunotherapy, also there is no much role for immunotherapy in children with asthma in the pediatric age, unless they have got associated allergic rhinitis and food allergy. It is very rarely used. I think only 2 centers. Amrita they are using, and in Rajagiri hospital they are using.
All other medical colleges, there are people, our own colleagues, Dr. Krishna Mohan is there, Dr. Nishra, Dr. Aparna from here, and all the institutions, they are looking after this asthma. But we should be sharing the experience. Otherwise, you know, I never used it. That's one. Another thing about the vitamin D, there was a study, Thrissur Medical College in Nisha studied. I don't know, I don't remember the result of the study, but whether it was more in a vitamin D deficiency states in younger children. That was the inference, I think. And regarding Krishnamurthy sir was also asking about the paracetamol. Should we reduce the paracetamol in intake by the pregnant ladies? And should we restrict the paracetamol in the below 1 year? Is it practicable? Because during the primary vaccination, it's there in the program of immunization, and we'll be using this thing. Just because the incidence of asthma is much more common in a very young child below 1 year, what should be our policy? We should have a policy regarding the paracetamol below 1 year by the IAP.
See, Purushottam, I will tell you, I have discussed this many times. Injudicious use of paracetamol should not be used. See, the commonest indication for using paracetamol in infancy, less than 2 months, is following vaccination. People are telling that they are giving paracetamol drops and say, immediately after vaccination, you should give this. Immediately after injection, you should give a paracetamol syrup for a paracetamol drop. That is not correct. I think if the child has high fever, irritability, you may give. Otherwise, you should not advise paracetamol for these children. And also, we seen that I was listening one of the talk by one of the specialists in immunology. He said even the use of paracetamol can reduce the efficacy of the vaccine also. Efficacy of the vaccine is reduced by giving paracetamol. So I think routine paracetamol should not be used, and you should not advise a paracetamol syrup or drops immediately after the injection. People say immediately after the injection. And also one more thing, I was working in the government sector for more than 30 years. I worked in the government sector. Then now for the last 18 years, I am working in a private sector. We give the acellular pertussis vaccine. But I have seen, I am not more commenting about acellular pertussis vaccine. If you are giving acellular pertussis vaccine, the fever, irritability, and all these problems are less. I will never prescribe a paracetamol tablet, paracetamol syrup for a child whom I have given acellular pertussis vaccine. Hexavalent vaccine. They are very safe, irritability is less. Nobody comes back with fever and irritability. I think definitely there should be guidelines for not using paracetamol regularly after vaccination. This is the commonest indication. For fever, let them give, but for vaccination, at least you must not give paracetamol pill.
But
Can I ask something?
Yeah, madam.
Purushottam Parnyo, continue. You want to say?
ഒന്നുമല്ല മാഡം, ഞാനിപ്പോൾ സാറിപ്പം പറഞ്ഞ ഒപ്പീനിയൻ, there can be a conflict between the recommendation by the government program, because in the program, when we discuss about the AEFI at the district level, state level and all, one very important point we are stressing is we are having many cases of seizures in even 6 weeks, 10 weeks, 14 weeks and all. And what we ask and what the recommendation is early introduction of the paracetamol, the seizure part. And so on one side, we are recommending early introduction of paracetamol. We are giving paracetamol. But the other opinion also, there can be a conflict in these recommendations. In the peripheral level, there can be a confusion.
Just a comment. I think by giving paracetamol, you cannot reduce the incidence of seizure, because we are giving vaccination for children less than 6, 10, and 18 weeks. 6, 10, 14 weeks. And then the chance of febrile seizure is very, very low. I think it will not occur. I think it will not, paracetamol will not produce the incidence of febrile seizure in this age. It will not occur.
Madam,
Excellent talk as usual, Dr. Sukumaran. And one suggestion, this Montelukast antihistamine combinations are rampant. Can't the IAP do something about it?
Madam, we have started against this years back, even from 2011, when I was the national president. We had a number of ATM, asthma training module. And also we had a training module for allergic rhinitis also. Again, we were asking, we were talking, we are approaching the government, but the companies are coming up almost all companies are coming with a combination of montelukast with levocetirizine. And also there are very few people like me who is not writing this combination.
I don't write.
All-
I don't.
Madam, very
I
well.
don't write.
Otherwise, all people are writing this combination very well. Even belastin with montelukast and this combination.
And you have to educate the pediatricians then not to write it.
Madam, we were educating for the last 20 years. We are educating, and especially through our ATM, and we have got a module for allergic rhinitis also. ARC ATM also, we are always talking about. Even ATM also, asthma training modules also, there's a chapter on allergic rhinitis and use of this combination.
Gobi,
Can I add something?
Gobi, Srinivas sir.
Dr. Krishnamurthy here.
Yes,
Dr.
sir, yes.
Sukumaran. Dr. Sukumaran,
Yeah,
just
yes.
something on the paracetamol after vaccinations. See, earlier, we used to give just the DTAP, and there was less incidence of fever with that. Now, with the use of hexavalent vaccine, which includes Haemophilus influenza B also, children do get high fever following that for the first 24 hours if you don't give them paracetamol. And as was already remarked, the incidence of seizures is higher in such children. So I am used to giving paracetamol 6 hourly for the first 24 hours, and I haven't seen any sort of reduction in the immune response following giving paracetamol. This is something that has not been proven or has not. I haven't found any studies which say that paracetamol should be avoided and it has low immunogenicity for the vaccine.
Dr. Krishnamurthy, what I want to say is that.
Any comments, Dr. Sukumaran?
Yeah, Krishnamurthy, I will say. See, for the last 5 years, 5 years, for the last 15 years, I am working in the private sector. We are using a hexavalent vaccine. With hexavalent vaccine, I haven't seen no case of fever. No case of fever, irritability in a child. With hexavalent, you are talking about hexavalent. I think it is very, very rare. I think definitely there are reports. Even you must read that purple book on immunization. They also recommends that the immunogenicity may be reduced by giving paracetamol. This is all.
Gobi, you may ask questions from the chat box, Gobi.
Sir, I will read out.
Okay.
What is the preferred one, salbutamol or levosalbutamol?
See, regarding this question, when you consider the effectiveness and side effects of levosalbutamol and salbutamol and dose, what I have seen is that levosalbutamol, the effect is less because we are just giving the half the dose of salbutamol. So I think the effect is less half. And also coming to the side effects, there is no much difference in the side effects. Like tachycardia and tremor is almost same. And levosalbutamol is not effective in children less than 6 years. Again, I want to highlight there are papers which shows that levosalbutamol is not effective in children less than 6 years. I think the salbutamol is a better drug. Efficacy is better, and side effects is almost equal.
So next question: how long can we continue montelukast?
It's all depends on the indication of giving montelukast. In allergic, the main indications of montelukast now is for treatment of allergic rhinitis. Allergic rhinitis, along with inhaled corticosteroid, you may prescribe montelukast. It can be given up to 3 to 6 months. There is no problem.
Sir, Nandoma here. Sir, Nandoma here. I only asked that question.
Yeah.
Because we people are telling that montelukast has got so many side effects, like neuropsychiatric side effects, including this suicide tendency. So if parents are coming and telling us, because of you only my child become SIP, and some other pediatrician who has happened to see this prescription, and they are just comment, this drug we should not give so long because there are so many side effects nowadays reported. So how will you handle that situation? That is the main issue, because the montelukast now so many people are against it. So how to handle the situation? That is my question.
Nandakumar, the main thing is that even FDA they say that the side effects are there. I think
Yes.
you must counsel the parents. The FDA says that you must counsel the parents before starting these drugs, and we should inform that there can be hyperactivity, suicidal tendency, etc. We should tell them. See, all the drugs are having some side effects will be there, but you must counsel them and tell them these are the side effects. If you want, you can start. But the suicidal tendency I have not seen. I have not seen, even though this reported is not seen. And recently, there is a paper which has come. Such side effects are not done.
So what is your experience in short term? That is
But
2
there
weeks,
is
3
no
weeks.
problem. There is no problem for short term.
Yeah. I think that is the best idea, I think, because nowadays all people are aware of the side effects and many doctors have started coming. That is very difficult for us to continue that.
But the thing is that, see, the most misused drug now is Montelukast. Even
Yeah.
for simple cold, simple viral cold, people are giving Montelukast.
Not for that, sir. Even for recurrent fever, if bystanders complains, my child is getting recurrent, if it's an Anganwadi child or some LKG, UKG, they'll get recurrent respiratory infection and fever. For that, they will give for months together, they'll give this
That is a nursery school syndrome. That is nursery
yeah.
school syndrome.
Along with this thing, as Madam rightly pointed out, along with that levocetirizine, the combination they are using.
I think for this nursery school syndrome, I think it is better that you advise vaccination, especially influenza vaccine may give some protection.
Thank you, sir.
Okay.
The next question: how long can we give leukotriene if indicated?
We are talking the same thing. 3 to 6 months is optimum.
Oh, sorry. Okay, sir.
The thing is that, see, what I have seen is that those children who have received Montelukast alone, they may respond initially. We give it for 3 to 6 months. Once you stop again, they will recur. So you have to restart again. And I think the ideal drug should not be Montelukast. The ideal drug should be inhaled corticosteroid in this setting.
So next question is: ketotifen has any role in prevention of preventive therapy?
See, ketotifen, we were using ketotifen years back, some 25 years back it was there. 25 years ketotifen. Ketotifen is a super antihistamine. It is only a super antihistamine. And there is no much more. But there are some papers which shows it is found to be effective as a preventer. But I have seen no effect for ketotifen. And now there is no mention about ketotifen in any of the books or journals now. It is not effective.
I think there is no other questions with chat box.
Okay.
Sukumaran sir, Dr. Nandaguma, maybe in the next year you're coming as a president. We should be training the pediatricians also during this rainy season. We are going to have many cases of the influenza infections and acute exacerbations of the wheezing. There's a natural tendency to ask for a nebulization with salbutamol without examination. So you are covering about the asthma mimics in a case of a long duration, but in acute situation also, we need always to exclude common dangerous mimics. 2, 3 things which you need to exclude in all cases of dyspnea presenting with the fever. Don't take it as an asthma always. It can be a case of cardiac, especially myocarditis or SVT presenting. It sometimes can be a pneumothorax or some of the situations of a metabolic problem, some of the poisonings and bite. So always educate the common practitioners not to miss this thing in a very fast, when the 2-3 minutes of examination, where to keep the steth and look for. At least once keep the steth over the heart for checking the heart sounds and tachycardia. Look on the both sides to compare, exclude the possibility of a pneumothorax. And of course, breathing depth. If it is deep, metabolic acidosis. If it is shallow, some poisoning. So some small training should be given to the busy during the busy OP. Thank you, sir.
One more point I want to highlight is that, see, when you auscultate the patient, it's always very important that you must look for asymmetric physical findings.
Right, sir.
Asymmetric physical findings. like diminished air entry, tracheitis confined to one side, or bronchial breathing to one side. It may be pneumonia or it may be foreign body. So asymmetric physical finding is always will be more serious, will have a more serious problem.
Very
And
important.
also, as I said before, in any child, especially under 5 BCs, there are a lot of mix are there. I told you must start with ABC or PC. Almost rule out all these conditions before you start giving nebulization. Especially you must rule out a cardiac problem like myocarditis or a congenital heart disease.
So that the stethoscope need to be kept over the myocardium, over the heart first, over two axilla and both
Back.
infrascapular. So that will pick up almost everything, sir. Gobi, is it over?
Yes, sir.
Okay.
Comments എന്തെങ്കിലും ഇല്ലെങ്കിൽ നമുക്ക് wind up ചെയ്യാം. കുറച്ച് നേരത്തെ ആയി.
Okay.
തോമസ് ആണോ ഗോപിയാണോ?
സാറേ wind up ചെയ്യാം സാറേ.
vote of thanks പറയാം.
സാറേ So thank you, Sukumaran sir. It was a very informative and an excellent talk. Thank you, all participants. Good night.
Okay. Thank you. Thank you, Vishwanath.
Thank you. Good night.
Night.
Thank you.